So it's an absolute pleasure for me to be here. My talk on AI-enabled cardiac MRI is something which is close to my heart, literally and metaphorically. So I hope this will be of interest to some of you in BioQuick and other people joining maybe today. So I want to start off with a quick recap on AI, concept of AI and AI and computer vision. So AI is something, you know, coming from the UK now, fresh from the UK, something coined by Alan Turing in the 1950s with the advent of the first computers and the Turing test. You might be familiar with, whether you can figure out whether something or somebody behind the screen is human or a computer algorithm. That's been a really, really old concept. Machine learning kicked off in the 1980s. I was spared from that in my PhD. I still did like more conventional image analysis. But in the 2010s, I had to throw my towel into the round as well and also move into the deep learning era. And the reason, of course, why deep learning only kicked off 2010s, even though it also was developed in the 1980s and 1990s. Actually, in Berlin, at TU Berlin, I've been implementing backpropagation and other deep learning things, Hopfield networks and all that. The reason why it kicked off that late in computer vision and then only even later in medical imaging was that we didn't have that many data sets. We didn't have GPUs full stop at the time. And we didn't have the annotations that we needed to train those networks. But of course, then ImageNet arrived in the 2010s. That's 13 million annotated images. Originally, it was designed for machine learning. So there were a lot of features extracted and labels provided, and conventional machine learning methods were devised. But then deep learning just overtook everything very, very quickly, and people just moved into that exciting field. And of course, I'm just showing you little things of you know, very, very simple networks in this talk. I'm not going into the maths or the complicated architectures. I'm just showing you some really vanilla style networks. This is an encoder network. It is encoding the information coming in. It's pooling the information together, basically averaging or doing max pooling. So just taking the most relevant information into a bottleneck. Basically, you can think of it as a compression of the most relevant information into some lower dimensional space. And then you've got some fully connected layer at the end, upon which then, for example, a classification decision can be made, whether there's a cat or a dog in an image. We can also make it binary cat or not a cat, for example. And these things, of course, can be kind of reversed. You can start doing transposed convolutions. You can do an encoder followed by a decoder architecture. Here's the famous UNet architecture, which has also these little connections in between. So information is also directly passed to the corresponding outbound layers. But the principle is the same. And here you can think of this as doing maybe not a whole image-based classification, but a pixel-wise classification, which allows you maybe to segment an image or classify an image into foreground and background, which gives you a segmentation. And you can use it for image restoration, for denoising, and so on. So this is computer vision. This is how it kind of started in the 2010s, becoming really ubiquitous. In medical imaging, we've been a bit slower, but that's because the nature of our data is quite different. We're not dealing with cats and dogs and traffic lights, but we're dealing with human anatomy, physiology, pathology, patients' variability, disease variability, and of course also different imaging modalities. In this talk, I'm just going to talk about cardiac MRI, so magnetic resonance imaging. You see a 2D sinus sequence, a short axis view of the heart, as you see it through the cardiac cycle, but actually you can regard this as lots of different frames. You can stack the frames up over time. You also might have slices in 3D as well, and then you have 3D plus time. And of course, you could think of other protocols, with contrast, injection, perfusion scans. So there's a whole arsenal of imaging methods you can think of here. But the principles are quite similar, what we want to achieve. We want maybe to segment the heart. We want to measure how many pixels are in the blood wall, in the left ventricle or in the right ventricle, or how thick is the myocardial wall, and to use that to get a better, improved, more robust, more automated clinical diagnosis. And then the architectures can be quite similar. We can, for example, decide on the level of image quality. We can say, is this good or bad quality? Again, we would just do something similar to noticing whether there's a cat or a dog in an image. So we just change our criterion here. We can use it to do the segmentation, as I just mentioned. And here UNet, actually that architecture actually lifted off in medical imaging, not in computer vision. So it's one of the rare successes where in medical imaging we were a bit quicker. Because in computer vision, they still use different kinds of architectures at the time. And then you can also think about reconstruction. You can think about image restoration, or actually really reconstruction directly from the raw sensor data from case space, or you can just use it for denoising. But you could think about how can you actually go from raw case space data, the raw sensor data, to the image domain. So in medical imaging, we typically fall into very separate, distinct categories. We either acquire images, so generating raw data using an image sensor, so decide on an image protocol, or we reconstruct images where we would transform the sensor data into an image which can then be viewed by the clinician. Or we do what's quite often kind of prerogatively called post-processing. We filter images, segment, maybe register them between one another, finding geometric alignment between images. We might do a bit more high-level image analysis, where we would construct models, patient models, breathing models, or we use them even to detect and classify disease. And this is where machine learning has been really probably the most successful in. And then in the end, we want to interpret these images or make the images suitable for interpretation by clinicians. And these are very distinct categories, which I'm connecting here with arrows because one is feeding into the next one. And AI in particular, deep learning these days, is increasingly applied within of each of these groups, not only in the post-processing segmentation stage where it probably started, but increasingly in the reconstruction and acquisition domain. Of course, in the model domain as well, because deep learning AI is just constructing models from data. It's completely data-driven model building, really. But where AI is, I think, has a really big potential is to think about applying it across these different groups and not just within this. And this is what I'm calling AI-enabled medical imaging, in this case, cardiac MRI. So we've got lots of challenges in here with when we deal with medical images. The image quality is quite often heavily compromised. There are image artifacts, there's patient motion, there's respiratory motion, there's physiological motion, for example, bowel motion. If breath holds are required, patients can't keep them quite evenly, so this creates also problems. And of course, they're sick. I mean, they wouldn't be lying in the scanner if there wouldn't be a suspicion of some disease. So this has to be taken into account as well. And the problem there is in any hospital, be it like the Klinikum Rechts der Isar in Munich or the Charité in Berlin or the Benjamin Franklin Clinic, you have the lack of availability of really nice, well-curated, annotated data sets, which we would need to train our networks in an easy way. And there's also something, which I'm not going into much detail here, is domain shift, because, you know, it depends on which scanner you scan and whether you follow up on a different scanner, whether you start putting different patient cohorts together who've been scanned at different hospitals. So it's not that easy. It's a bit different to switching just the camera in ImageNet. But there's this huge potential where we can apply deep learning along this entire imaging pipeline, right from acquisition to clinical interpretation. And we can think of this in a very modular way. So we just apply it for acquisition or for reconstruction or for segmentation. But we can increasingly integrate this, so can do, which I will show, like a joint reconstruction segmentation approach. And we can start thinking of end-to-end approaches, even where we would just really go almost from raw sensor data to a clinical diagnosis. And these approaches can be really useful for, in the first instance, image quality control, which is something I've been increasingly working on, but also image reconstruction, so improving the quality of the images during reconstruction or for reconstruction, and then subsequent downstream tasks like segmentation or image analysis. So in cardiac MRI, of course, we acquire those images for the assessment of cardiac health, and that's done routinely in the hospital. The image quality there is based on the underlying imaging physics, in this case, the MR scanning system. And then there's this trade-off, especially in cardiac MRI, because you're imaging a moving, twisting object, contracting object. So there's a trade-off between the signal to noise and then between the spatial resolution and the temporal resolution. And that, of course, is dictated by the acquisition time, the time you have available. And the patient physiology is here really important to think about, because you're imaging a beating heart. So there is breathing motion also of the heart. It's not breathing, but during breathing, it's moving a little bit up and down. And you need to do several breath holds because you need to cover the entire cardiac cycle and the different planes. And of course, there's other motion of the patients as they lie for a longer time, maybe up to 30 minutes or 40 minutes even in the scanner. And that often results in images which are of subpar quality, which need to be chucked out, discarded, or you are not able to annotate them because you don't quite clearly see the boundary of the myocardium. There's really some blurring motion and other things. And that's because normally images are acquired and then only later the radiologist inspects them and then say, actually, I can't use that image. I have to recall the patient. And that affects, of course, greatly hospital workflow. You've wasted time, you've wasted a slot. But most importantly, actually, it's delaying clinical diagnosis, and it could be too late for some patients. And I know of cases where patients were not recalled quickly enough, and then they actually had a health problem then. So image quality control is then a topic which actually lends itself very nicely to AI, because people have been looking at that in computer vision. They've been trying to denoise images, do super resolution imaging and other things. Here we took this approach that we say, okay, our hospital data is not good enough for training and to generalize to all kinds of data. So we've looked at the best quality data we could get our hands on. And we looked there at UK Biobank, which is a large funded program where I can't remember how many 100,000 volunteers were originally invited for health assessments and biomarkers and record them. But 7-8 years ago, 100,000 of the original volunteers were invited back. And they were imaged for brain, heart, and whole body imaging with different modalities, predominantly MRI, but also some ultrasound, some CT, and some PET as well. And they were scanned across very dedicated imaging centers across the UK, really purpose-built just for UK Biobank, tight quality control, same scanner manufacturer, same protocols, scanning protocols, high scan consistency as well. And of course, you've got other things. You've imaged the brain, and the liver, and the heart, but also bone measurements for bone density, but ultrasound of the carotid arteries and other things. So there's a lot of wealth of imaging data. There's a lot of also genetic data and other biomarkers. You just see some examples of the quality of the images, and you see here for chamber view of the heart and the short axis view, scenic views of the heart, but you actually have this whole body image as well. So if you think about what you could use AI for in this context is, well, you could maybe use it to simply establish whether a patient needs to be rescanned or not. Basically, is it good quality or not good quality? And ideally, you would do that almost at scan time. So while the patient is lying in the scanner, you would say, oh, that was not good. Let's quickly scan again, right? So let's not waste time with recalling the patient later. Let's just, do it better now. But you could also think about using it to establish or curating your own databases. So basically just trying to pick out the good from the bad and the ugly and use it to really curate an own in-house database using AI. That would be the first step for image quality assessment. The second step would be to say, well, okay, it's retrospective. We've got some poor quality images. Is there something we can do to avoid patients having to be rescanned? Also, sometimes it's not possible to rescan them because we might want to compare their current scan to something which was taken 6 months or a year ago, or maybe even 10 years ago. And of course, we can't rescan them like 10 years ago, but we still have an image which we have to deal with. And the other reason why you want to restore images is you want to solve some downstream tasks a little bit better. You want to be able to segment them. If the image is poor quality, your segmentation will be poor quality as well. Or you might not classify disease because it's obscured by image artifacts. So you basically want to salvage the images. And then the final goal, I think, is to actually make imaging faster. Because I mentioned before, you've got a certain time window. It's always like, I don't know, 25, 30-minute protocol. Most of that time is used for patient setup in the scanner as well. But sometimes you don't need all the data you acquire. Sometimes you just want to do a quick check, want to rule out some condition. So you could stop imaging quicker. And that not only would increase patient throughput, which radiologists, of course, like because they get more people off their list. But you could also allocate scan time maybe a bit more dynamically. You could allow more time for more dedicated scans for some patients where you see a problem from this really first rough scan and say, actually, let's dive into that and that and that. And then for another patient coming, you say, actually, I've ruled out what I thought you might have. You can already leave. We don't need the whole scanning slot. So that would be the ideal scenario. Next step would there to be predicting, you know, how much time you would need for each patient. But that's another story. So I mentioned before, you can classify images into maybe good and bad quality, and this is really, you can use a very simple encoder architecture. You don't have to do anything high level. You just present a network with a lot of good quality images and a lot of bad quality images, which are labeled as such. Train your network, freeze your network after you finish training, and then you can just show it some examples, and hopefully with this frozen network showing this poor quality image, it will tell you this is poor quality. And this, in a way, is similar to just recognizing whether there's a dog or a cat in the image. So there's really no rocket science behind this. But we thought, actually, is there an actual image quality problem that we are interested in? And that's some work I think I showed to some of you, if you're still around, like 2-3 years ago when I was last in Berlin, where we said, well, there is one actual scanning problem, something where you really want to be able to classify images into good and bad quality. And that's really incorrect scan planning. So here you would see an image on the top, where you see a 4-chamber view on the top right. This is an image you might want to acquire. But before you can actually acquire that image, you have to acquire a 2-chamber view and a short axis view through the heart. And you have to place an appropriate angle in the short axis view, and you need to be careful to exclude the aorta as well. So once you've done that, only then you can position, you know, your scanning direction in a way that requires the correct 4-chamber view. But if you do this incorrectly, then you are slightly off axis. So you've got like a slightly strange view, which shows you the left ventricular outflow tract, where this little red arrow on the bottom right is pointing towards, and that gives this 4-chamber view a so-called 5-chamber look. And that image you can throw away because you can't do the further downstream atrial analysis. You would have to recall back in the patient. And that's happening quite often in the clinic because things have to happen very quickly, and you have to place the angles and acquire the images, and you might just not notice it because the reconstruction usually still takes a little bit of time as well. So you would only find this out later and have to recall the patient. So the idea is it could be detected very quickly here. So we've done this was really one of our first attempts at doing this. So we looked into UK Biobank and selected images of good and bad quality. So I without and with the left ventricular outflow tract present, we automatically crop those images using template matching, just vanilla image processing. You could do object detection, like find the bounding box. Created then a 2D data set consisting of good and bad quality images. Trained the most simple Yann Lequin network from the almost early 1990s, I think, but on these images, and traded against poor or good quality labels. So that was the idea, which was done by Ilka Okshius, my postdoc at the time at King's College London. Now the problem was we worked with UK Biobank, which is really nice, high quality data, 100,000 of really good, generally good quality scans, and mostly healthy volunteers. But of course, some of the volunteers actually might have a cardiac condition as well because it's a cross-population study. But we did find from our first batch of 3,000 or 4,000 images, 123 images where actually the LVOT was present, despite all the tight quality control happening in UK biobank. The incidence of that to happen in hospitals would be much higher, of course. But we then chose just randomly 123 good quality images, just to have two balanced classes, good and bad quality. And we did additional data augmentation. That's basically translating, rotating, zooming the images, cropping them, just to give a bit more variety to the network. Of course, because these were cine data sets, we could pick several temporal frames from each sequence. That gave us then 615 images for each class. So actually that was more reasonable. Of course, we had to be careful when we divide the data up into training, validation, and testing, that patients or volunteers are kept together with all their different temporal frames. But we treated them as independent data sets otherwise, just not with respect to training and testing. And we did tenfold cross-validation just to increase the robustness of the statistics. And here was just our initial results there. We also compared classic traditional machine learning, so nearest neighbors and support vector machines and random forests and so on, and looked at accuracy, precision, and recall. And we found that our convolutional neural network CNN approach outperformed all of them quite easily, without any effort, really, which at the time I was still quite agnostic, skeptic about deep learning. And that was the first time I said, well, actually, maybe there is something to all that hype. And also we saw there, which I thought was interesting, that data augmentation, which is just basic data augmentation, really just translating, rotating, scaling, and so on, also made a difference. It actually boosted the performance yet by a couple of percentage points. I still needed a bit of convincing, because I still think, well, this is a black box approach. We don't quite know what does the network learn. It's still an active area of my research now, is just to think about what does the network actually learn inside. But just to give you a bit of an idea, you can look inside the network using the attention maps. Basically, once you convolve, you input data with the frozen filters that you've trained on. You get all these feature maps out, and then in the end you have the attention maps, which allow you to classify the images, and you can look at them. You can actually visualize what's going on. So here's an example where the LVOT was present. Here's one where it's not present. So poor quality and good quality image. And then if you look at the corresponding attention maps of these images, you can actually see that in the left case, in the poor quality case, the focus of the network is on the area, on the region in the image where the LVOT actually is located. And on the right-hand side, it does focus on the separation between the heart chambers where there's no LVOT. So it always looks at the right place to decide whether it's a good or bad quality image with respect to LVOT. If the criterion had been something different, it probably would have focused somewhere else. So the next step is to think about, can we salvage images? Can we restore them? Of course, in the case of the LVOT, we can't. We really have to rescan the patient because the scan was just really incorrectly acquired. But we might have scans which have some other artifacts in there. And actually, could we go from the left-hand side from poor quality to a good quality image using any kind of magic network somewhere in the middle? And the idea is also, can we do this from the raw sensor data? Because maybe some artifacts are quite acquisition related. So it might be actually worthwhile, rather than already going through the reconstruction, could we do it straight away? How do we do that? So I always feel that if we try to improve images, segment or restore anything else, it's good to understand a little bit of the underlying imaging physics and acquisition. So you actually understand, where does this artifact originate from? Why do we have that problem in the first place? So here's just two examples. Here's a good quality image on the left-hand side and a motion artifact on the right-hand side. So it's different to the LVOT. This is a short axis view. But you might not see the difference immediately. You might see, well, okay, the left one looks a little bit brighter and is a bit of a bigger heart, might still be a very diseased heart for all I know. But the right-hand side has poorer contrast, smaller, and then you might think, well, maybe it looks also a little bit blurrier. And if you look carefully at the myocardium, that black ring, basically that little donut-shaped ring, and you see it's actually starting to get quite blurry into the blood pool. So it's not quite clear where does the myocardium end and where does the blood pool start. And this is exactly the problem which is quite common in cardiac image acquisition, because remember, the heart is beating as you acquire it. So there is something like a temporal motion blur happening here. And that motion blur can be understood by thinking about how the images are acquired in the first place. So you would normally do ECG triggering, and you would know exactly at which point in the cardiac cycle you are at any one time, at any one breath hold that the patient has to do. And if everything goes well, you would just go through that cardiac cycle, knowing with the trigger where you are, and would fill the corresponding frame with a few new lines. And then in the next leap of the heart to the next part of the cardiac cycle, you would move on to the next frame, keep on filling there until you've gone through several cardiac cycles, several breath holds, and will have filled all the lines. And then you would do your inverse Fourier transform, and you would get your images out. Now, if something goes wrong, if the trigger is wrong, that's quite common, because remember, you're imaging patients and they've got maybe arrhythmia. And so actually that is almost a medical problem, that the ECG would show up in a diagnostic sense. Here the ECG is just used for, trying to help you navigate through the cardiac cycle. But if something goes wrong and you've got a wrong line in case space, there's something we shuffled. Oops, sorry. Go one back. Oops. One back. Okay. So one line is maybe misplaced at the place I plus J on the bottom. Then you start having corrupted frames. Yeah. Then you started mixing different places of the cardiac cycle together. And once you reconstruct, only it will become apparent. So again, we were faced with the problem that UK Biobank didn't have much of that problem. We had access to tens of thousands, up to 100,000 high quality images of volunteers with very careful ECG triggering. But as I said, in the clinic, you're more likely to have this poor quality image. And we still want to be able to deal with these images and restore them. But since we now know how this artifact actually originates, where it comes from, we can use that to our advantage, and we can artificially generate realistic images which have exactly this kind of ECG mistriggering artifact. So we can go back to K-space, not quite, we can do an inverse Fourier transform at least, and we can start mixing up K-space lines as much as we want across the cardiac cycle. Then reconstruct the images again, basically do a inverse Fourier transform again. And then actually we can actually generate the images of increasing levels of low quality. So really good in making good images look bad, But obviously what we want to construct pairs of these images, poor quality and good quality, so we can train a network, teach it to actually go from low quality to good quality. And this is a way to basically doing physically realistic data augmentation using some knowledge of how images are acquired. So in the end, it's similar to actually doing data augmentation by bringing around a cat. But in this case, actually, we're really creating data pairs which help us to do supervised training. So our first attempt was to look at this method by Zhu et al., which was published in Nature, where they learned any kind of image transform, it was quite an astounding paper. If you want to have a look at it, it's a bit difficult to get, because all you get is this image and no real algorithm, and you have to kind of reverse engineer what they show you here and see how does it work, and actually found much faster ways since then to do that. But basically they start with complex sensor data, because that's your Fourier space. It could be also still sinograms from PET data. They're actually completely imaging agnostic in their paper. So it could be any kind of modality, but MRI is what they actually wanted to do. And they basically use fully connected layers of complex dimensions, then some convolutional layers, and then finally deconvolution. And with that, basically showing a network lots of K-space data and lots of reconstructed data, they actually learned the inverse Fourier transform. Or a Radan transform, or God knows what, because they also looked at other modality images. This was so complex, it only worked in 2D and took ages. So we kind of found some smarter ways later on to do that. But the idea was quite neat that you think you can actually learn an image transform. You don't have to rely just on your Fourier transform. And this becomes especially interesting when you look at undersampled data. And this is where these things started to lift off, because you have to overcome your problem with the Nyquist frequency. And these methods actually can get away with that because they just know how good data should look like. But we thought at the time, well, a lot of people have been looking at undersampled data sets in this case. This was exactly what AutoMap was constructed for. But we really want to do artifact correction. We don't have sparse case space, we just have bad case space, like with wrong lines. Yeah, so instead of having an undersampled complex case space as an output, some reconstructed high resolution image, we actually have as an input a fully sampled corrupted complex case space, and as an output we want an artifact corrected image. And you can, make it a bit clever and putting in some discriminator, a bit like what generative adversarial networks are also doing, to kind of make sure that the image quality is still improved at the reconstruction. So the idea was then to say, okay, we can synthetically corrupt data. So you don't see from the case space that it's a poor quality image. If you just would do an inverse Fourier transform, this is what you see in column B. If you did our approach there from the beginning, you see some other reconstruction, to which I'll come in a moment. On the right, you see the original high resolution image, because we actually had the good quality from good quality data from biobank before we corrupted it. You might say, and I think you're right, that column C looks much more blurry than the original, and looks much more blurry than the Fourier transformed image. But it's anatomically more correct, or physiologically more correct. It's at the right cardiac cycle, as opposed to the Fourier one, which is a completely different one, because actually it is doing that exactly that motion blur in a different direction than where it should be going. But you can also look at real corrupted data. So we also looked at it kind of without our simulations, just saying, okay, can we do something with that? Of course, case space, I don't read case space. I wouldn't know whether it's corrupted or not. If you just do the Fourier transform or our method, you get also similar effects, and you have to look quite carefully to see the differences there. Anyway, but the next idea was, well, we don't want images to look nicer or less noisy or anything. Is it helpful in any way? Can we actually get better quality segmentations out of it? So we just took a state-of-the-art segmentation method. This was the work by Vijay Bai from Imperial College in a joint grant that we worked on. And if you just take a poor quality image versus a good quality image, in this case we deliberately corrupted the original good quality image, and just run the segmentation as a post-processing step, you see it fails in the poor quality image step. And these are the images you normally don't see in publications, because normally you only see the left column and not the right column if people present a new segmentation method. But segmentation will fail. It will stand and fall with the quality of the images. And you could also say with the quality of the images it was trained on, because to some degree, you could also train on a poor quality image if you have a good quality segmentation label against it. Only in this case, you probably wouldn't be able to do a good quality segmentation of that image because it was so corrupted. So the idea then was to think about, can our artifact removal help with the segmentation? So we compared different methods. Here I'm just showing column C method called Win5 by Peng. And our proposed one on the right, on the far left, the original and corrupted image, just those two columns I've just shown you on the previous slide. And you see that the Win5 method just applied out of a box, the segmentation failed, whereas our proposed method actually did get out some good segmentation. It might not be perfect if you look very carefully from the far right to the far left, but it certainly will not have completely failed. Yeah? So it could be maybe even reused diagnostically. So that was interesting. That was just a sequential approach. Let's restore images, remove artifacts, and then segment. And we did, I think somebody has their microphone on, maybe you, I hear you yawning, makes me tired as well. Can we remove artifacts, and then how much does the segmentation improve? So we had different methods where we removed artifacts, just listed there on the left with the references on the right. And we did two different methods, the ones proposed on the bottom, one which just as the loss function, basically the objective criterion in the training, uses mean squared error, MSE, and then one which actually also uses something which is called SRSIM, structure simulation index measure, which actually is used in reconstruction quite often as a quantitative criterion to evaluate the quality of the reconstruction. Here actually we've used it to optimize over it. So we can't use it then in the evaluation anymore, but we managed to improve the volume overlap. That's the Dice coefficient. The mean curve distance was reduced, and the Hausdorff distance, which gives you the worst minimum mismatch between two curves, also was decreased. So it's good for outlier detection as well. So then we looked at this a little bit further and said, well, moving a bit away from AutoMap, we said, well, is there a better way? And we thought, well, actually, the problem is we've got wrong case baselines. There is some analogy to undersampled imaging, to undersampled MRI reconstruction, where people have some undersampling trajectory, just shows a certain set of case baselines, maybe around the center where you want to catch the low frequencies of the image. You acquire that sparse data, have an undersampled case space, which would create you an image of a low resolution, but training against high resolution examples where you would throw away case space just for the sake of training. You can, with addition with the data consistency network, you can actually get a high resolution reconstruction. So that's just vanilla image reconstruction using deep learning. But here in this case, we actually have a fully sampled acquisition, only that some of our case baselines are wrong. So basically what we then said, well, but we can train also a detection network which identifies which lines of case space are wrong. We can do that because we can train in a supervised fashion, because we can create images with wrong case baselines from our super duper UK Biobank data. So at the same time as we are detecting wrong case baselines, but would create an artifact-affected image, we also can reconstruct the image, detect the lines, remove them, and transform this whole problem into a undersampling problem. So we can actually get a reconstructed high-resolution image, which also has the artifacts corrected. That was a neat trick, and we took that slightly to the next level by saying, let's not just throw in single 2D images, let's throw in the whole scenery sequence. Because in the scenery sequence, there's a lot of redundancy between the different frames. Also, there is probably some coherence in terms of the case baselines that have been swapped across. We didn't go that far to reshuffle the case baselines, so we put them where they should have been, because that would be the next step. But some lines might still be missing or doubly acquired even. And for that, you then need to use a recurrent neural network approach, RCNN. We used a lot long short-term memory networks, LSTMs, which actually exploit that redundancy between the cardiac frames. The rest is then the same. We use the data consistency term. We identified in the detection network the wrong case baselines across the whole senior sequence. And as an output, we get our 2D plus time corrected images. And then basically what happens there, the way you do it jointly, you have a more complex loss function which optimizes both the detection loss and the reconstruction loss. And this is still the MSE as you see here, but you could also plug in the SRSIM for the reconstruction loss. Okay, so again, we went to UK Biobank, our good database. We selected 200 CNS scans for training and 50 for validation and 50 for testing. Pre-processed them to get the region of interest out of them. Just showing all the parameters here. It was really quite straightforward. So we have here deliberately corrupted image on the bottom and a good quality image on the top. And then on the left-hand side, we detected the corrupt case baselines, again, compared against a couple of other methods, including Win5 and our previous AutoMap GAN approach, which I showed right at the beginning. And then we tried out different things. You can actually do it separately. First you detect lines, do undersample, and then just reconstruction, or train it jointly or end-to-end, as we say here. Hello? Somebody talking. Or you can also, just as a test how good you can get, give the detection, instead of doing the detection network, actually give it the knowledge where the wrong case baselines are. Yeah, so this is as good as you could get. So if your detection network would work 100%, this is what you would get in terms of PSNR and root mean squared error in a system. And then on the right-hand side, we also applied to uncorrupted data where we thought, well, there's no wrong case baselines or nothing that we can see. So we actually don't have a baseline. We don't know how good it would be, but we still found for our error measures improvements. So that actually shows that you could actually use this as a multi-purpose reconstruction tool because it seems to be beneficial to the data. Here just some movies, I hope they're visible for you for playing, where you see the corrupt image on the left across the cardiac cycle. Then after reconstruction, we get a much clearer definition of the myocardium with the two different approaches, the automap gun approach and the proposed PSNR approach. And then on the right, you see the difference image, the ground truth, sorry, you see the ground truth in the third column, and then the difference image on the right, where you actually see less difference using our proposed approach. So then we went on and said, well, can we actually improve further downstream tasks, such as segmentation? So can we improve the images and then run a segmentation? And as I showed you before, it might break if we actually have artifacts. This is an artificially degraded image on the right, but can we do something about it? And then we thought, actually, let's not do it sequentially, let's do it jointly. So looking at our previous network, could we plug in also a segmentation network at the same time? So what's happening is that our training objective just becomes a little bit longer. So rather than just having a detection and a reconstruction loss, we also have a segmentation loss. We can plug in some vanilla UNet network there at the same time. And then you see here on the bottom, this is again an artificially degraded image, which we can quite nicely then quantify how good we got. So you see the poor quality image on the top left. I'm not sure whether you see my cursor, but if not, then you see the difference to the original good quality image and the segmentation, which doesn't look too great. And then on the right-hand side, you see our restored image, the difference to the original good quality image and the segmentation. So we also did this prospectively. We actually put in a volunteer who can do really nice breath holds and had no ECG mistriggering problems into the scanner. We required two sets of scans. One where we deliberately performed ECG mistriggering during the acquisition. So we deliberately perturbed the ECG so the data was wrongly binned in the case space. And we did a good quality image, as good as we could do at the time. And here you see what happened then. So on the far left column, on the figure, you see the real artifact image as a result from deliberate mistriggering and the resulting subsequent segmentation. On the far right, just as a comparison, you see the good quality image acquisition and the resulting segmentation. You see hopefully the differences. And then the middle two column, the second column shows the reconstruction, motion reconstruction, basically the previous approach, then followed by a segmentation. The third column shows the joint motion reconstruction and segmentation. And if you especially compare those three images on top, you see that actually not only the segmentation improved in our joint approach, our integrated approach, but also the reconstruction, because the reconstruction was forced to focus on also producing a good segmentation. So it was actually reconstruction with some goal in mind, that the purpose of the reconstruction was also to improve the segmentation. So it had an impact also on the reconstruction and not only on the segmentation. Yeah. We then went one more step, I'm nearly done, where we said, well, could we use this for cardiac function as well? So we started off with image acquisition and just classified images into good, bad quality. Rather than restoring images here, we looked at the further downstream AI protocol. We said, well, we can segment the images, we can compute parameters, After the segmentation, we can actually, and the computation of the first parameters, the ventricular volume curves, we can do another quality control step where on the basis of these profiles of volume curves, we can accept or reject scans. And only once we are happy with their quality, we actually move on to the actual ventricular function. And we did that together with the cardiologist. We looked at 700 cases, 500 healthy cases, and 200 with ischemia. And we found that actually this quality approach gave us human level accuracy with really good levels of agreement between the cardiologists and our pipeline. So it was really validated against them, and we had really high sensitivity for volume, strain analysis, and so on. So this is how AI can actually help in actually the post-processing and the clinical diagnostics. And you can start thinking about putting all these things together, the reconstruction and the further downstream analysis in a nice way. And then the final thing we did is something which is really work in progress, but we really want to accelerate the image scanning by ensuring that the image quality is good enough. So when can we stop scanning? When will our segmentation be good enough with a maybe undersampled scan so we can actually move on to a function analysis? Again, we picked data from UK Biobank and did a retrospective facial undersampling. So this was different. There's actually it's Cartesian sampling in UK Biobank, but we were interested in moving forward, and we just used that as a test case. And we did 2 quality checks to assess the reconstruction quality and to assess the segmentation quality, and only then moved on to the volume curve analysis. And what we found is that you can actually reduce your scan time from 12 to 4 seconds per slice and still stay within a 5% error in all these measures. That was nice. You actually save, 2/3 of your time. And you can think of this whole pipeline as leading you through. You acquire images, we did retrospectively, so we had different undersampling trajectories ranging from 3,000 milliseconds to 9,000 milliseconds for a single slice. We did our first quality control just on is the image quality good enough or bad enough. Did a full cycle, only if it passed it, we did a full cycle segmentation, did then the segmentation quality classification step. So does the segmentation quality pass the quality check, and only then did the volume curve analysis and so on. So you could even have other quality checks further down the road as well. Right, so machine learning and AI in particular, but deep learning in particular, has the potential to be really transformative in cardiac MRI. So it can really operate along the whole image pipeline. It can do so separately in a very modular fashion, or you can integrate it more and more and even think about end-to-end approaches where you can really go straight maybe from the image sensor to clinical interpretation. You might, with this approach, derive some information already during scan time. So you can actually, before you even reconstruct data, decide whether the quality will be good enough or not. So you can even think about classifying case-based data directly. And with that, you can really influence positively or impact positively the hospital workflow and patient management. And think about going all the way with AI. I'd like to thank all my funders who helped in this endeavor, especially my computational lab at King's, who've been working really hard on this, and the Smart Heart project team shown on the right, which is where this program grant is from. But of course, I've got more and more people working in this field now that I'm at TUM and Helmholtz. And thank you for your attention. Here are just some exciting things I'm really passionate about. We are running a registration, so motion correction workshop in Munich in July. Please drop by if you want to go to a real conference for a change. We still hope to have it in person. We are taking MICA, our main conference in medical image computing, computer-assisted intervention, for the first time to Africa in 2024. And for this purpose, we've also founded a new African network for artificial intelligence and biomedical imaging, Africa. You can go and visit the website. And we've launched a new free open access archive overlay journal called melba.org, Machine Learning in Biomedical Imaging, where we're looking forward to your submissions. Thank you very much.